about chest tumors, and I have to take this opportunity to send a big thank you to Rolf, because as most of you, but maybe not all of you know, we would not have these symposia, none of these activities in Zurich. So thank you very much again, and stay with us for some time.
Well, thank you, Michael. And without Michael, it would only be half the fun of what we do. So, chest tumors, my disclosures. I said we want to go to some practical aspects, and I'll start with a patient of mine. The patient presented with a neurological deficit. She was to the emergency room, a large and a small brain metastasis was discovered. The tumor underwent resection. It was an adenocarcinoma, TTF positive, no oncogenic driver. The patient was then additional SBRT to the tumor bed and to the other brain lesion. The next treatment, the patient had also adrenal metastasis and the primary tumor in place. The treatment concept was chemotherapy, and because it's oligo-metastatic disease, stereotactic radiation to the primary tumor and to the adrenal metastasis, which resulted in a very nice response in March 16. But in May 16 already, the patient popped up with a lesion in the face, and you see in the PET-CT scan, there was a metastasis in the salivary gland, which was proven, and a bone metastasis in the pelvis. So what was the treatment at that time? Obviously, we again did SBRT to the two lesions, and nivolumab treatment was started in May 16, and you see here this is in February 19. And obviously, from being unable to work, going to part-time working, then the patient is fine, no side effects, takes up a full active life. And the discussion, what was this discussion? Obviously, how long do we treat? So, how long do we treat? What are the evidence? There's evidence from a community oncology trial, not very strong parameters, but it suggested if you stop nivolumab after a year, you see that is the blue curve, the red curve, the progression-free survival is unacceptable. And many of the trials that were ongoing have had unlimited continuation of treatment. And the other trial, the important trial with pembrolizumab, here the prescription was 2 years of treatment, and that treatment with pembrolizumab for second-line non-small cell lung cancer stopped. These are the survival curves. Now, what happened to those patients that were in remission and treatment was stopped at 2 years? It was 79 patients, and 31% had disease progression after. So this was discussed with this patient, and I can very understand the patient has said, this is too high a risk. If I tolerate the treatment well, we'll continue, and that's why we treated beyond 2 years, at almost 3.5 years. Of course, one can then say, can the patient respond again? Now, the data is very scarce. Here in this study, 14 patients of those 25 had a second course of pembrolizumab. Only 6 had an objective response. Okay, so here we decided to stop the treatment because, you know, it's every 3 weeks treatment, and the question is, does it really need to be every 3 years? And we did the final evaluation. And he had a CT of the thorax, and there was a new lipidic lesion, which was resected, and is an adenocarcinoma, TTF1 positive, PD-L1 negative. So what I want to show, there is clear evidence that immunotherapy doesn't prevent the occurrence of secondary primaries in the lung, which is also an important topic. You know, can we prevent, because the secondary primary is the highest risk in lung cancer curative treatment. So what do we know? Which patients have a good response to the treatment? There's an analysis on nivolumab, pooled data. It is performance status 0. It's much better than performance status 1. Liver metastases, bone metastases, they have decreased odds of survival. The other thing is the depth of response. You hear those in green are patients who have a 5-year survival, and it's clearly associated with the depth of response. And the other thing that was shown in this and in other publication, the likelihood to have a higher survival chance, a higher chance of progression-free survival is associated with immune-related side effects. Now, of course, if you have a patient treated for 3 or 4 years, they want to go on vacation, they ask you, can I miss a dose? And it's very clear, the evidence is there from a single infusion. The occupancy of the circulating T cells is 100 days, and then when you have multiple infusions, there's absolutely no reason why you need to stick to the every 3 weeks in a patient that you follow. But, you know, most patients now get a flat dose, and what do we know about dose and effect? And I think very little is known, but it has an interesting publication I want to share. So 220 patients receiving nivolumab, 3 mg per kg, 1,700 plasma sample analyzed. It shows that women have a lower clearance than men by 22%. A high body surface area and a low serum albumin is associated with an increase in nivolumab clearance. Now, what is the effect? If you look here at clearance and progressive disease, stable disease, and objective response, there seems to be a relation to it. And we never, take care of that in clinical practice. And then you look at those curves. You have on the left-hand side progression-free survival, on the right-hand side overall survival, the highest clearance, red, or the lowest clearance in blue. So it makes you pause and think, what we do with this flat dosing. The other thing is, we give patients second-line treatment, and of course, all the clinical trials is performance status 1 and 0. But in a country like Switzerland, where the honey flows, we can give, immune checkpoint inhibitor to everybody. And the question is, but it's not the case in all the countries. So if a patient has a poor performance status, you see here on the left-hand panel, this is nivolumab, performance status 2 to 4, or palliative care. And here the immune therapy is not much better. And despite of that, of course, it's very hard to deny the patient a treatment, and we may also treat patients with a poorer performance status. On the right-hand side, the same for the pembrolizumab data. Also, here it was shown that severe pneumonitis was clearly associated with those patients with a poorer performance status in this analysis. Now, can we exclude patients because it's very unlikely that treatment works? I'm sure Burkhard will have, there's a lot of ways to do it, but I have to tell you, a test to exclude a patient to deny treatment is totally unattractive. We all want to do a test that gives something to the patient. But you could do it nowadays with a multi-panel analysis. If there is LKB mutation and KRAS mutation at the same time, the likelihood in the red of an objective response is very small in lung cancer. But we do not use it because we don't use a test to deny patients. But if you work in a resource-restricted environment, you might use this for your clinical practice. So the ESMO guidelines, say you test for PD-L1 only after you have excluded oncogenic driver treatment. I'll leave that alone. And the high PD-L1 expression, the standard of care is pembrolizumab. These are the trials. There are 4 trials that looked at chemotherapy since 30 years, platin-based combination, or immunotherapy. And we have 2 trials that here led to FDA approval. One is pembrolizumab for 50% PD-L1 expression in the tumor, and the other, FDA, but not in Europe, hopefully, is pembrolizumab for higher than 1% PD-L1 expression. So the data is clear. High PD-L1 expression, the standard of care is single-agent immune checkpoint inhibition. On the red-hand curves, this is the control with chemotherapy. The majority of patients received immunotherapy later on, so you can clearly say it's good to treat immunotherapy upfront and not later on. Of course, there's a caveat to this, and this also needs clinical investigation. We don't have data. You see here in the blue, the Keynote 22 trial. This is patients with a strong PD-L1 expression, a progression-free survival, even treated in blue with pembrolizumab or in red with chemotherapy. And you see that the curves cross for progression-free survival. But all the trials with data that we have for high PD-L1 expression, the curves never cross if you combine chemotherapy and immunotherapy. Of course, you could say on the blue things, you can keep chemotherapy for later on, but without clinical trials, which so far nobody funds, we do not know what is the right approach. How about patients who have a very strong PD-L1 expression? Here it's 90% or higher. And you see here, it seems to be a clearly degree. The very high PD-L1 expression, the patients do very well in this observation from Japan. This is the data that led to an FDA approval in the red box of giving pembrolizumab for patients who have a tumor with at least 1% of PD-L1 expression. And of course, it's positive. But when you go up, the whole positivity is driven by the patients who have a strong PD-L1 expressing tumors. So in my mind, this is not going to be a standard of care for everybody. But, you know, you can have a different opinion in that regard. Again, here I want to say again, if you compare these single-agent immune checkpoint inhibitor trials, there is a crossover in terms of progression-free survival, but there's not a crossover when chemotherapy and immunotherapy is combined. And, you know, since most patients have just one shot, you make it or break it initially, my tendency is to use the combined treatment. Now, a big thing for immunologists, Ipi/Nivo, or the combination of a CTLA-4 with a PD-1 or PD-L1 antibody, and we'll go a little bit on that. We have 2 trials, which we have some data. None of those trials leads to a regulatory approval, but it gives us some interesting food for thought. The one trial looked at, after 10 remodeling of the study design, it looked at patients who had lung cancer with a high tumor mutation burden, 10 mutations per megabyte base. Now, here, the top curve, Ipi/Nivo, the combined treatment was better in terms of progression-free survival. Survival was not significantly different. It hasn't led to approval. The similar trial, they looked at Ipi/Nivo, CTLA-4, PD-1 combination in patients who had a lung cancer with PD-L1 expression in the tumor of 1% or higher. And we have a press release from July. I think we hear it at ESMO, the data, and this trial is supposed to be positive. So, yes, means as compared to chemotherapy. Of course, we have to see the data, but it's of interest because we may change the initial approach. And there has been another trial. This is now tremelimumab, together with durvalumab, which is a PD-L1 antibody. And here in the post-hoc analysis, it was very clear. Patients who had a high tumor mutation burden, this is in blue, and measured in the blood in these situations, had a much better outcome than patients who were treated with chemotherapy. Since it was a post-hoc analysis, it does not lead to approval, but it's food for thought and future development. So I summarize on that part. Pembrolizumab single agents is a standard of care for high PD-L1 expressing tumor. Combination with platin-based chemotherapy based on the individual tumor assessment is an alternative, and I think might be preferable. The use of single-agent pembrolizumab for patients with a low PD-L1 expression remains controversial. And the CTLA-4, PD-1 or PD-L1 combinations might become alternative if the trials that really look at it prospectively have a positive readout. Now, for all other patients that present with non-small cell lung cancer and the PD-L1 expression is not there or it's low, the standard of care according to ESMO is chemo-immuno combinations. And these are the trials that have read out for patients who have a non-squamous non-small cell lung cancer. 2 of the trials have led to regulatory approval in the US and by the European Medical Agency. This is Keynote 199 and atezolizumab 150, and I just shortly point out to those trials. This is a patient with adenocarcinoma of the lung treated with chemotherapy, platin-based combination, or in the experimental arm green, the addition of pembrolizumab, and it's a clear survival benefit. Again, despite that on patients who failed with chemotherapy, a lot received immunotherapy later on, and this is now a standard of care. A similar positive trial has been a trial which used as a standard more American-based regimen, paclitaxel, carboplatin, bevacizumab, and I looked at the addition of atezolizumab to this combination. Again, the trial is positive for survival, and it has 2 very interesting parts to it, which made us pause to think for future work. It is the only trial where the hazard ratio is very much in favor for immuno-anti-angiogenic therapy for patients with liver metastases. And it's the only trial data available which is so positive for patients who have an oncogenic driver mutation. And I'm sure Rousseau will, in his talk about the combination, will go more in details to this. And he's going to be the chair of this, the PI of the next ETOP study we called ABC Lung, which tries to confirm that in this setting. Now, this is short, that the patient with squamous cell non-small cell lung cancer, we have 2 trials which have read out. One led to an approval, the addition of pembrolizumab to carboplatin paclitaxel-based chemotherapy as a standard of care. So, first-line therapy for patients with immune checkpoint inhibitors from combination. Pembrolizumab combined with carboplatin pemetrexed is emerging as a standard of care for non-squamous non-small cell lung cancer. Atezolizumab combined with carboplatin, paclitaxel, and bevacizumab is an alternative option, in particular for patients with an oncogenic driver mutation in the tumor or maybe dominant liver metastasis. And for squamous cell carcinoma, it's the pembrolizumab chemotherapy combinations. Now, how about earlier stages of disease? For adjuvant treatment after curative resection, we have 4 large clinical trials that are ongoing, and they will read out in a few years. Now, there has also been very interesting trial, the same as melanoma, to give immunotherapy before resection. And one has seen major pathological responses by just 2 doses of immunotherapy, and this concept is now being investigated in large phase 3 studies. The other one is already a standard of care. All patients who receive curative intent chemoradiation for stage 3 disease, we know that consolidation treatment with durvalumab provides a survival benefit and is a standard of care. And I will show a slide on it. We're going to look now in the future in oligo-metastatic disease together with our friends in radiotherapy. I wanted to show you this response. This is data from a multicenter trial in Spain, and here patients who were surgical candidates for stage 3 disease received 3 cycles of chemotherapy and nivolumab prior to surgery. And they found a major pathological response in 85% of the patients. So this is very, very encouraging. And of course, at the end, we need to demonstrate a survival benefit in phase 3 trials. We take part here in the IMpower 30 trial, which looks at the atezolizumab upfront combined with chemotherapy and as consolidation, but there are other phase 3 trials ongoing. This is the data of Pacific. This is patients with stage 3 disease that get chemotherapy, radiotherapy, which is the standard of care, concomitant treatment, and a consolidation, placebo-controlled in this trial, with durvalumab is associated with a survival benefit. And again here, it's the first trial in stage 3 disease since 30 years, which has shown an advance of whatever has been done before. Now, you know, when we go to this curative intent concepts with stage 3 disease, the question is, can we cure patients with oligo-metastatic disease, or can we derive a major benefit? And here we have a study again in ETOP that will start in 3 countries very soon. It's the idea to give a maximum treatment. Patients with oligo-metastatic non-small cell lung cancer are being treated with chemotherapy, concomitant durvalumab, and upfront SBRT to all metastatic sites. At evaluation, then, the definite treatment for the primary tumor will be either radiotherapy or surgery. And with this kind of a maximum treatment, we really like to document that we can achieve more. So, my last slide. I'm doing right because I didn't look at the time, but it's my last slide. So, small cell lung cancer. Despite some positive signals, the phase 3 trials of second-line or consolidation immune checkpoint inhibition with small cell lung cancer, phase 3 trials was a failure. There is a published phase 3 trial of using atezolizumab together with chemotherapy upfront, and again, this is since 40 years, the first advances in extensive disease, small cell lung cancer. It's modest, but it's the first advance in terms of survival. For mesothelioma, there is many small phase 2 trials which shows, yes, immune checkpoint inhibitors gives a response rate, but there's no phase 3 data. And the first phase 3 data is again from ETOP and will be presented at the ESMO meeting. And of course, I cannot devolve because it's under embargo, so you have to keep the attention. With this, I want to thank you for the attention.
Thank you, Rolf. Any questions or comments?
I was excited to see that you acknowledged those pharmacology data on the checkpoint inhibitors. So showing that the patients with a higher exposure have a better outcome. I discussed this very actively with the Dutch group, and there are people that believe in that. Do you think we should look at it prospectively?
Well, it's of course, I think we probably overdose all those patients with much too much drug. And it could be, when I travel to China, I said, why don't you give half the dose, and you probably have the same effect for half the cost. But I think who we need to look into that, it's not going to be the companies for approved drug, so it has to be academic centers, and the Netherlands Cancer Institute is certainly a good place for pharmacological investigations. I'm surprised this is the only trial I really found on this topic, and I was really surprised about the difference in outcome according to clearance.
Okay, thank you very much. So we come to the last